So should I start?
Yes, please.
Good morning, everyone. Topic for today's seminar is anti-craving agents. So we'll start with what is craving. Craving mainly refers to the strong desire or urge to experience the effect of a previously experienced psychoactive substance. There are three novel pathways of craving: the reward pathway, craving or desire for the rewarding, stimulating, or enhancing effects from the dopaminergic dysregulation. The relief pathway is the craving or desire for reduction of tension, arousal, or withdrawal from the GABAergic dysregulation. And the obsessive pathway, which is the lack of control over intrusive thoughts about psychoactive substance, resulting in the impaired functioning resulting from the serotonergic dysregulation. Dopamine is recognized to play an important role in regulation of reinforcement and reward through the mesolimbic pathway from the ventral tegmental area to the nucleus, which is crucial for reward. Unlike the natural high, the activation caused by the drug's abuse can cause changes in the reward circuitry that is associated with the cycle of preoccupation, craving, dependence, and withdrawal. Similar to many impulsive compulsive disorders such as pathological gambling. First, we'll start with alcohol dependence. The treatment of alcohol dependence still remains a challenge. 10% of world's population is affected by alcohol use disorders. The most common treatment for promoting abstinence, reducing alcohol intake, and preventing relapse are psychosocial interventions, that is, cognitive behavioral therapy, motivational enhancement therapy, self-help groups, that is, Alcoholic Anonymous, and the use of medications mainly represented by anti-craving drugs. Alcohol craving plays a crucial role in alcohol dependence, and it is among the main determinants of alcohol relapse. So far, only three drugs, disulfiram, naltrexone, and acamprosate, have been approved by the Food and Drug Administration for the treatment of alcohol dependence. Nalmefene, a drug for opioidergic activity, has been approved for the treatment of alcohol dependence and will be commercialized in some European countries. First, we'll start with disulfiram. Irreversibly inhibits the action of aldehyde dehydrogenase enzyme, causing the accumulation of acetaldehyde during the ethanol intake, which leads to acetaldehyde syndrome. It is characterized by heat in the face, purple rash in the neck and torso, tachycardia, hypertension, nausea, vomiting, diarrhea, and headaches with breathing alterations. These symptoms appear 5 to 15 minutes after drinking alcohol and last from 30 minutes to few hours. Test drink is not needed and it does not lead to a better treatment outcome. The contraindications for the use of disulfiram are severe liver disease, peripheral neuropathy, optic neuritis, and psychotic patients because it has a risk for exacerbating the symptoms of psychosis. Dosing. Treatment with disulfiram can only be started with 800 to 1200 milligram per day for 3 to 4 days, at least 12 hours after the last intake of alcohol. It is then reduced to 400 milligrams per day until the 7th day. It is maintained with 200 milligrams per day for no more than 6 months. Treatment can be restarted after at least 30 days of discontinuation. It can achieve a positive result in cocaine-dependent subjects. Naltrexone, it is a mu-opioid receptor antagonist. Effect is produced by the reduction of dopamine release in the nucleus accumbens located in the ventral tegmental area of the limbic system. Alcoholic patients who continue to drink during the treatment with naltrexone thus report being less inclined to consume large amount of alcohol. It works by anti-reward craving. Usual dosage is 50 milligram a day orally, starting 4 to 7 days after the last drink, or in people still drinking to cut down the amount of alcohol intake. Efficacy is reported at 50 to 100 milligram per day in combination with psychosocial treatments. It has proven to reduce the relapses by 36%. The side effects include headache, nausea, dyspepsia, anorexia, sedation. It is usually avoided in patients with severe liver disease. High levels of craving, positive family history of alcoholism, and presence of a severe polymorphism in the mu-opioid receptor gene appear to predict a positive response to naltrexone. 50 to 100 milligram per day orally for 3 to 6 months is the recommended dosage. Monthly doses of 80 milligram intramuscular naltrexone guarantees a better patient compliance. Acamprosate. Acamprosate presents a neuroprotective effect. Antagonist activity on the N-methyl D-aspartate glutamate receptors. It modifies the transmission along the GABA and glutamine pathways. And there is a subsequent reduction of the excessive flow of intracellular calcium ions. It should be considered as the first-line treatment to maintain abstinence, both in reducing alcohol craving and in maintaining abstinence. The main side effects are transient diarrhea, headaches, and dizziness. It is not recommended in patients with renal failure, but is safe in patients with liver disease. Available as 300 milligram enteric coated tablets. Recommended doses and duration of the treatment are 2 daily oral administrations in weight less than 60 kg and 3 daily oral administrations for 1 year for weight more than 60 kg. Recommended to start 5 to 7 days after the last drink. Nelmifem is a mu and delta opioid antagonist and kappa opioid partial agonist associated with a reduction of heavy drinking. It should be avoided in patients with alcohol withdrawal syndrome who need a symptomatic pharmacological approach and immediate alcohol detoxification. Doses are 18 milligram orally as needed for 6 months. Sodium oxybate is a short-chain fatty acid structurally similar to inhibitory neurotransmitter gamma-aminobutyric acid, exerts an ethanol-mimicking effect on GABA's receptor in CNS. It was FDA approved for cataplexy in narcoleptic patients in 2002, but it is observed that 40 to 70% of alcohol patients achieve and maintain abstinence from alcohol. Recent study by Cochrane Review highlighted that sodium oxybate is superior to naltrexone and disulfiram in maintaining alcohol abstinence and is reducing alcohol craving with respect to disulfiram. Side effects: 30% of patients treated with sodium oxybate experience side effects, namely dizziness, sedation, asthenia, which disappears spontaneously after initial administrations. Anti-craving medications with alcohol mimicking property to be used in patients with reward and relief craving. It should be avoided in patients with polydrug addiction and access to borderline personality disorders. Dosages are 50 to 100 milligram per kg per day every 4 to 6 hours for 7 to 10 days to treat alcohol withdrawal syndrome, and 50 to 75 milligram per kg per day every 6 to 8 hours for 3 to 12 months as anti-craving. Approximately 10% of patients develop a craving for a drug with very limited episodes of abuse. Baclofen. Baclofen is a GABA's receptor agonist, mostly on the postsynaptic receptors in dopamine neurons, responsible for reduced release of dopamine. A controlled clinical trial showed that baclofen is significantly more effective than placebo in reducing and in maintaining alcohol abstinence in treated alcoholics. Dose begins with 5 milligram 3 times a day, and the optimum dosage is 30 milligram and 75 milligram. 70 to 375 milligram per day were able to significantly reduce the alcohol consumption in alcoholic patients with psychiatric comorbidities. It has shown to reduce the risk of relapse in high-risk drinkers and is more suited for patients with chronic and severe disease with advanced liver disease. Adverse effects include sedation, nausea, impairment in ability to drive, visual and urinary disturbance. Abrupt sedation may lead to seizure or confusion. Now, topiramate, it inhibits the positive reinforcement induced by alcohol through the facilitation of GABAergic activity, which in turn inhibits, there is an inhibition of glutamatergic activity and decreased release of dopamine in the limbic system. Dosage is initial dose. It started as initial dose of 25 milligram per day, which is progressively increased by 25 milligram per day to reach a maintenance dose of 300 milligrams per day for 3 months, reducing the mean daily intake and increasing the relative days of abstinence. Ondansetron, it is a 5-HT3 receptor antagonist. Serotonin plays a key role in alcohol drinking. Dopaminergic, it leads to, it affects the 5-HT transporter activity, which leads to dopaminergic downregulation. There is reduction in the reward from alcohol. The dosage is 4 microgram per kg twice daily, reduces the alcohol craving. Other anti-craving agents are pregabalin, 50 to 450 milligram per day, more effective than naltrexone, suppresses the alcohol withdrawal symptoms and reduces craving. So anti-craving effect, side effects being abuse potential. Oxcarbamazepine is dosage is 1500 to 1800 milligrams per day, beneficial than naltrexone in reducing number of relapses. 1200 milligram per day, similar efficacy to naltrexone, and is used in comorbid psychiatric disorders like borderline personality and bipolar disorders. Valproic acid, 750 milligram per day, reduces alcohol consumption and is used in patients with bipolar disorder. Opioid dependence. Although craving is a subjective phenomena, it can be triggered by environmental factors like drug-related cues. In opioid, craving may occur to alleviate the withdrawal symptoms, which is the negative craving, and to experience the euphoric effect, which is the positive craving. Opioid-dependent subjects have a lower baseline of D2 receptors in the caudate, high dopamine release in the putamen, and chronic craving and anhedonia related to dopamine release. Well, the craving centers are the bilateral inferior frontal cortex, orbitofrontal cortex, and mesolimbic area. Substitution therapy, long-lasting impairment in the striatal dopaminergic neurons, more prominent in the methadone-maintained patients compared with patients with prolonged abstinence. Agonist, it is an agonist at mu opioid receptors. Effective maintenance for the treatment of heroin dependence by retaining patients in treatment and decreasing the heroin use more than non-opioid based replacement therapy. Methadone maintained patients with a history of heroin dependence remains responsive to salient drug cues, which suggest a continued vulnerability to relapse. Methadone may help in heroin craving, but patients receiving MMT may still be at risk of cue-induced heroin craving and relapse. The initial daily dosing of methadone is 10 to 20 milligram. Onset of action is within half an hour, and the peak plasma levels achieved approximately 2 to 4 hours of dosing. Higher doses of methadone, like 60 to 100 milligrams per day, are recommended as they have shown to be more effective than lower doses in retaining patients. Need for gradual titration over weeks to reach a therapeutic range of 60 to 100 milligram once daily. Dose increases should not exceed 5 to 10 milligram on each occasion and is not usually more than 30 milligrams in first week above the initial starting dose. The side effects being it leads to QT interval prolongation on the EEG, which is associated with Torsades pointus and can be fatal. Now, buprenorphine. Buprenorphine and naloxone in combination and buprenorphine alone are safe and reduce the use of opiates and the craving for opiates among the opioid addicted patients. Received in outpatient settings, milder withdrawal symptoms and therefore may be preferred for detoxification program. It is able to reach a therapeutic range of 12 to 16 milligram once daily over a few days. Available in combination with naloxone, which may prevent diversion for injection. No more than 8 milligram buprenorphine should be given on the first day. For maintenance, the orange guideline recommend a dose between 12 to 25 milligrams a day. Patients in withdrawal and no risk factors should be given a dose of 8 milligram. Patient not experiencing withdrawal and no risk factors should be given a dose of 4 milligram. Patient has concomitant risk factors like medical condition, polydrug misuse, low or certain severity of dependence on other psychiatric medications. They should be given a dose of 2 to 4 milligrams. Methadone is of equal efficacy to buprenorphine in reducing prescription of opioid abuse, in prescribing opioid dependence, and retaining people in the treatment. Now, naltrexone. Naltrexone treatment has been found by NICE to be the cost-effective treatment strategy in aiding abstinence from opioid misuse. Supervision of naltrexone administration and careful choice of who is prescribed it, those who are abstinence-focused and motivated, are very important. Adverse effects of unease, dysphoria, depression, and insomnia, which may lead to relapse to illicit opioid use while on naltrexone treatment or failure to continue on the treatment. Naltrexone has a propensity to cause severe withdrawal reaction in patients who are either currently taking opioid drugs or who were previously taking opioid drugs with no sufficient washout period. The minimum recommended interval between stopping the opioid and starting the naltrexone depends on the opioid used, duration of use, and the amount taken as a last dose. Opioid agonists with long-acting half-lives, such as methadone, will require a washout period of 10 days, and shorter-acting opioids, such as heroin, may require up to 7 days. Washout period of up to 7 days is sufficient. Final buprenorphine dose of more than 2 milligram and duration of use more than 2 weeks. Naltrexone may be started within 2 to 3 days of patient stopping when the buprenorphine dose was less than 2 milligram and duration of use was less than 2 weeks. It is started as initial dose of 25 milligrams per day and monitored for 4 hours after the first dose, and it subsequently increased to 50 milligram daily dosage as a maintenance dose. Nicotine. Bupropion is FDA approved for smoking cessation. It has antagonism of nicotininergic acetylcholine receptors, dopaminergic effect on reward mechanism, indicated for smokers over 18 years of age motivated to stop smoking. Adverse effects include dizziness, taste changes, gastrointestinal disturbance, and insomnia, which can be reduced by avoiding the dose close to bedtime. The contraindications to the use of bupropion are seizure disorder, eating disorders, and alcohol dependence. The daily dosing is on day 1 to 6, the dosage is 150 milligram per oral bupropion once daily. 7 to 49 day, 150 milligram per oral bupropion twice daily with an interval of at least 8 hours between the doses. And on day 50 to 63, 150 milligram per oral bupropion twice daily if the person has stopped smoking, discontinued, person has not quit. Now, finally, varenicline is recently approved as a synthetic drug for cessation of smoking. Varenicline is a selective nicotininergic anticholinergic receptor partial agonist and causes a sustained release of dopamine in the mesolimbic pathway, and therefore comes under the category of nicotine replacement therapy. These are my references. Thank you.
Good morning, everyone. House is open for discussion. Please put up your questions in chat box or ask.
Dr. Tanya, you have not put references in all the slides, so it's difficult to understand from where you are recommending the different regimes. So I would specifically like to ask you about the regime for disulfiram that you suggested.
Yes, sir.
Where is from where have you taken the reference for that?
So there's an article from which I have taken the references.
No, but what is the strength of disulfiram that is available in India? Can you come to the slides where you recommended that disulfiram?
Yes, sir.
Okay, next. Dosing, yes. So what's the difference from this?
So I've taken it from this article. The pharmacological management of alcohol dependence from monotherapy to pharmacogenetics and beyond.
It's just an article. It's not in the guidelines, the dosing
No.
or the recommended by the that is recommended by product monograph. It is not usually followed, right?
Okay.
You should also you need to tailor your talk according to the drugs that are available in India. Here it says 200 milligrams daily, so we have a 250 milligrams dose, right?
Yes.
Most of the places is 250 and 500. The regimes are according to that only. Second is about the bupropion regime that you said for smoking.
Yes.
75 milligrams, 150. Yes. Can you come to that? So doses, yes. Where have you taken this from?
So this is from Maudsley.
Maudsley.
Yes.
Okay. I'd like to check up. How do you start bupropion in smoking? What is the, how do you start? What directions do you give? If the patient has come with smoking, so you want to start bupropion, what would you do?
So first we'll counsel the patient about, first we'll check the motivation, whether he is motivated to stop smoking or not. If he's motivated, then we'll start him on an anti-craving agent like bupropion.
Okay, then what will you do? Oh, like how do you go about it? When does the patient quit smoking? Does he quit smoking before starting bupropion?
No,
With
sir, it
starting,
takes within few weeks to months, it takes to stop, to decrease the amount of smoking intake.
what? So, what is the procedure? You want to initiate bupropion in a patient? What is the procedure? So you need to come prepared for these questions,
Is there any quit date we set?
Yes.
Do we set any quit date? That is what actually routinely is prescribed.
Yes.
Like, we start bupropion, we set a quit date 2 weeks after initiating bupropion, and dose shall be tapered, but the dose shall be adjusted as per the tolerability. And maybe after, because it takes 2 weeks for the pharmacodynamic takeover, and then when patient leaves smoking, generally they won't report craving. But issue with this is generally patients are not very compliant when we ask them to set up a quit date, and there is some difference as per these representatives in the formulation also. Some says that SR preparation acts better in liquid and withdrawal.
Sustained release, immediate release, that
Yes,
it's different.
it's different. So why it is different also, it's interesting, we can look into.
Yes.
Okay, thank you. That are all of my comments. I would suggest that you put references in the slides, at least in dosages, okay, so that somebody can check up and
Okay. Okay.
and use which are recommended in guidelines that are better than the articles. It may be difficult to defend, right?
Yes.
And taper it according to the scenario in India. Baclofen also you've said 5 mg TDS, right? So I'm not aware if there is 5 mg available here with us. Right, that's all. Thank you.
Thank you, sir.
So, good reference also probably can be the Rakesh Lal's textbook of substance use disorder, which he has tailor-made in our context. My few comments are just to summarize everything. So when we talk about alcoholism, we say that naltrexone is preferred when we want to have patients, to push the heavy drinking down. Acamprosate is number of these drinking days has to be less. So we prefer acamprosate, or abstinence is the goal. And if patient doesn't respond to both, then disulfiram comes into picture. And then these second line agents like gabapentin and topiramate. This is very clearly mentioned in APA guidelines 2018. APA 2018 is the recent one which has come up. So they have actually categorized it in this format, and I think it is very easy to they've summarized it very vividly. So all of us can go through that. And regarding baclofen, NIMHANS has actually churned out papers left, right, center for baclofen role in alcoholism and other substance use. Somehow we tried it in a lot of patients here. We couldn't get the robust response. As per the literature, it takes care of this Q-induced craving. So, but I agree with sir that whatever information we have taken, it has to be corroborated with our current availability, like sodium oxybate. It's not available in India. Nanmefin you're not using currently. So we can actually add these two lines. Okay, we need to know the drugs, but maybe the last line can be added. This is not available in India. This we are not using or not available in Uttarakhand. This kind of a thing. Methadone. There are very few clinics in India with methadone. So that kind of information will also help us to know and learn better.
Yes.
Anyways, you presented well. Slides were better. Your confidence was very good. You have tried to cover a lot of areas, which can be difficult in 20 minutes presentation. So presumably you have done well. I think that is from my side. Thank you.
Thank you, sir.
Any queries or comments from third years, final years? Tanya? Mr. Srinivasan has put up a question in chat box. Please answer that.
Q exposure is when the patient is exposed to a stimuli that induce craving for the substance. Example, alcohol or tobacco.
So Q exposure craving can become a part of, it's a part of a craving. There are different types of craving. You mentioned reward craving,
Yes.
obsessive craving.
Obsessive craving.
Then there are other types of withdrawal craving. So craving which happens in withdrawal. So there is a similar kind of a craving which is Q-induced. Whenever there are cues, the patient, environmental cues, the patient will start. So it's a part of craving.
Yes.
Kind of a craving.
Thank you, everyone.
So here we end the presentation. Thank you so much.